Good evening, everyone. It's again Usama Saleh from Dubai Shoulder Course and the Emirates Orthopaedic Society for our series of webinars. Today, I have the pleasure to introduce to you three of the eminent speakers. The very well-known worldwide Dr. Joseph Iannotti from Cleveland Clinic in USA. Then the other speaker, my friend here from Dubai, Dr. Bhuvan Machani. He's a well-known shoulder surgeon in UAE right now. He was practicing for the last couple of years in UK, then he moved recently to Dubai. Our third speaker is one of the pioneers of shoulder surgery in Egypt, Dr. Mohamed Gamal Morsy from Alexandria University. He's a professor of orthopedic surgery and the head of the Department of Sports Injury in Alexandria University. We will start first with Dr. Bhuvan Machani. He will talk to us about the basics and biomechanics of reverse shoulder arthroplasty. Then we will move on to our superstar today, Dr. Iannotti. He will talk about how to manage bone loss in reverse shoulder arthroplasty in both the primary setting and revision setting. And finally, we will have a very nice presentation from Dr. Gamal Morsy. He will give us a nice tips and tricks and evidence-based medicine on reverse shoulder arthroplasty in trauma setting. Welcome, Dr. Iannotti. And welcome, Dr. Machani and Dr. Morsy. Thank you for accepting our invitation and being with us today. Today, I have the pleasure also to introduce my co-moderator, my friend, Dr. Ali Maqdisi from Kuwait, and he is the co-chair with us in Dubai Shoulder Course. Thank you very much, guys, for being with us today. We will start first with Dr. Machani.
Hi, good evening, everybody. I'm sure you're going to hear a lot about excellent things from my future panelists. But like anything else, the basics is very important to know what the actual facts are. For those who have not read, I think this is a very good article to just freshen your memories about the biomechanics of the reverse total shoulder arthroplasty. So are you controlling my slides? I can't move them. Okay. So why did it first start? I mean, the irreparable rotator cuff tears lead to superior migration, which creates a shoulder pain. The shoulder pain is mainly because of arthritic surfaces. Does lead to weakness due to loss of function of the rotator cuff, and the formal arthroplasties failed badly. The initial processes were based on Mark's evolution, which was a fixed fulcrum, reverse ball and socket processes, and the glenoid was keeled and cemented. Mark type 1, this had a larger ball, allowing more motion. Mark type 2, the small ball and cuff attachment, but less range of movements. And finally, the Mark III component, which was giving some axial rotation in the humeral stem. All this failed badly and were abandoned in the early 1970s, and mainly due to severe constraint. So this brought on to mainly one man who evolutionized the reverse arthroplasty, and the 5 components, which include glenoid base plate, glenosphere, polyethylene cup, humeral neck, and the humeral stem. They are based on 4 key principles by Grammans, which include the center of rotation must be fixed. This has to be distalized and medialized to the level of the glenoid surface. The processes must be inherently stable. And the lever arm of the deltoid must be effective from the start of the movement, not at the middle or the end. And the glenosphere must be large and the humeral cup small to create a semi-constrained articulation. So if you compare the figure to the left to the right, the lever arm and the deltoid force, L2 and F2 is definitely more than the figure on the left. What it does mean means the torque, which is the product of the force and lever arm, increases, which in turn increases the deltoid tension on lifting and lowering the arm. So this is the basic essence of that one. So looking from the axial view, concentrate on zone 1 anteriorly and zone 4 posteriorly. These are the deltoid fibers anterior and posterior. They, in a native anatomy, they're mainly adductors, but on medialization of the center of rotation, the zone 1 and the zone 4 fibers, which are anterior and posterior fibers, are recruited to actually elevate and abduct the arm by the deltoid. So this is zone 1, zone 4. So how does the deltoid actually cope with the lengthening? The total tension is dependent upon the active tension of the muscle during the contraction and add up the passive tension. You cannot change the active tension itself, but you can actually increase the length of the resting tension, which increases the passive tension, which in turn, active tension plus passive tension is increased. It optimizes the length for maximum tension of the deltoid. Rootman's prosthetic designs, it looks a bit complicated, but it's fairly easy to understand. Medial glenoid, lateral glenoid, middle humor, and lateral humorous. Medialization of the glenoid means the center of rotation of axis is less than 5 millimeters from the native, and the lateral glenoid means it is more than 5 millimeters. Medial humerus means offset less than 15 millimeters, and lateral humerus offset more than 15 millimeters. The medial glenoid does increase the deltoid lever arm, but may have a strain on rotator cuff musculature. Likewise, the lateral glenoid, it has less deltoid function, but better rotator cuff stability. So in various combination of middle glenoid, middle humerus, lateral glenoid, and lateral humerus, the processes have evolved to match the specific needs of the patients, and you can increase or decrease whatever way you want. The eccentric positioning of the glenoid is the key. In a center glenosphere, adduction is actually limited by the direct contact of the polyethylene cup on the inferior glenoid ring, and abduction is actually limited by the subacromial or subcoracoid impingement. By spacing the glenoid eccentrically, this increases the range of motion in both adduction and abduction. So the inherent stability angle is stable as long as the net joint reaction force points inside the concave component. By increasing the cup depth results in large alpha values. Unequal radii of curvature and a limited constraint confer impingement-free range of motion. In a total shoulder arthroplasty, the ratio of the stability is 1, but in reverse, the actual stability is more than 2. So how do you actually reduce or avoid notching? So this has been a game plan, a game changer for every shoulder surgeon. Releasing soft tissues inferiorly to restore humeral length, inferior placement of base plate, they're all okay. But I think the new key things now coming are inferior glenosphere tilt, larger head, eccentric hemisphere, and bio-RSA now are coming more and more. This is another nice topic to read, or if you've not got hold of it yet. So how do you actually decrease the scapular notch? Can be various. The positive notch angle is at the point where the scapula starts to notching. You can change the angle of humeral neck shaft inclination by changing the depth of the polyethylene, by lateralizing the center of rotation, and downward inclination of the glenoid component, increasing the glenosphere, and creating an inferior prosthetic overhang to the glenoid bone. Let's go one after the other. The neck shaft inclination, if you look at the difference between 145 and 155 degrees, the scapular notch has less when you have more 155 degrees as compared to 145 degrees. Cup depth, just by increasing 3 millimeters, you can see the notching decreases. And by lateralizing the base plate just by 5 millimeters, you're once again, minimizing the scapular notching. The downward inclination of the glenoid component, just to about 10 degrees, has a good effect of decreasing scapular notching. And likewise, increasing the glenosphere of the radius has a positive effect of decreasing the scapular notching. Inferior prosthetic orang is probably one of the key factors. You can get more adduction and more abduction, and minimizing the scapular notch at the same time. There are some evolving trends, lateralization, augmented glenoid to address glenoid deficiency. We're going to hear more about that in the next speaker. Patient-specific guides and computer-assisted navigation to improve peg or screw placements. Why lateralization? There were problems with the regular RSA, including scapular notching, instability, limited shoulder rotation, and loss of shoulder contour. So there are different ways you can lateralize. It's a metallic lateralization, or you can do a bony lateralization. Lateral offset, medialization of the center of rotation slackens the rotator cuff muscles and decreases the respective moment arms by as much as 36%. And you can see the figure on B to D, the rotator cuff muscles, especially in subscapulars and the teres minor, they get tautened or tightened when the lateralization has been done. However, the lateralization may be less important or no significance if the glenosphere is placed in an eccentric position. The various options of the glenosphere, which again is useful in different patients. And there is again now talk about the angles of 135, 145, 155, which is better, or a short-term prosthesis. The influence of humeral neck shaft angle and the glenoid lateral and range of motion, it's shown that if you use 145 degrees, the external rotation and adduction and external rotation is increased, while as abduction is decreased. And glenoid lateralization by just 5 millimeters gives equivocally a very good rotation of 40 degrees external rotation, adduction 15, external rotation 15 degrees, and flexion as well. This is a nice article by Ortho from Canada. This is a fine element model analysis, 3 angles, 2 spheres, and 3 cups. 3 angles are 135, 145, 155, and 2 spheres, which are 38 and 42, and the other cups are deep, normal, and shallow. It is to assess the contact area and pressure areas. And the maximum contact area was achieved with 155 degrees, and 135 had not so great effect. And likewise, big sphere had a good effect as compared to small sphere. Some points about the rotator cuff, there was no measurable difference between the subscap repair group and the subscap deficient group for dislocation, range of motion, or outcomes. Rotator cuff function seems to be better when the posterior cuff is intact, and the concomitant cuff repair increases the deltoid force required for abduction, especially for lateral humerus designs, and this shows about 29% increase in joint load. Thus, humeral stem may be used in place of rotator cuff repair. Short stem, it's new. I'm not going to say much about the benefits, yet to see the long-term survival analysis. We'll wait for that for the future. Thank you.
Thank you very much, Dr. Machani, for this very nice review for the basic science. We will move on with our second speaker, Dr. Iannotti. He will talk about the severe glenoid bone loss in reverse shoulder arthroplasty.
Thank you all very much. I appreciate the opportunity to present. So there's a lot of difficulty around getting glenoid fixation and as just talked about, the importance of lateralization of the glenosphere when there is severe glenoid bone loss, either in primary or revision arthroplasty. So I'm going to try to talk a little bit about how to manage this, how to plan for it, and the outcomes of reverse arthroplasty, both in primary and revision. And I'm going to try to do that by virtue of presenting three challenging cases. So the first one is a primary arthroplasty. This is a patient with bilateral severe shoulder pathology and polyarticular rheumatoid arthritis, and he's a fairly young patient, 53 years of age. He's had many years of long-standing pathology, and his rotator cuff was intact, at least anatomically, but from a functional level, because of the rheumatoid arthritis, the tissue was deficient but intact. And you can see here, these are his preoperative x-rays. I hope you can see my pointer, but you can see very, very deficient glenoid and sort of the splayed out anterior and posterior glenoid wall, and the severe medialization of the humeral head, where the humeral head is at least 1.5 centimeters medial to the lateral most portion of the acromion. So one would be very, very concerned in this patient, not so much on the humeral side, but will there be enough bone for fixation, primary fixation? And there would be consideration in this type of patient to say, I might not get good fixation and might have to either do a hemiarthroplasty on the humeral side with a bone graft and wait for the bone graft to heal, and maybe do a second stage. And there might be a chance that with good, reasonable bone that you get good fixation. So that's the preoperative planning, at least from a strategic perspective. From a anatomic perspective, you know, obviously you're going to get a CAT scan. We're going to do some 3D planning on the CT. And again, you can see in this patient the severe bone loss and the difficulty that you might anticipate with getting screw fixation. This is the 3D plan, and you can see in both these types of software, and this is software that we developed here at the Cleveland Clinic, and then down below, this is the DJO software. But you can see in this plan, we're going to try to get a little bit of fixation on the base plate and also use the periphery of the glenosphere to add additional contact between the glenosphere periphery and the bone graft to additionally support the screw fixation of the base plate. So you really want to look at not just screw fixation from the base plate, but to use the contact of the periphery of the glenosphere to add additional fixation and support. So this is the surgical plan. You can see we're going to get probably only about 25% of the inferior part of the base plate on native bone. And then the rest of this is going to be the humeral head of the bone graft, which is obtained from the humeral head. And you can also see that we're using this alternative center line. Normally the screw would come out through the anterior wall, but you're trying, if you can, to get this screw, center screw, down the medial column of the scapular body to try to get some additional fixation. So this was the postoperative result. You can see we got reasonably good fixation. Again, this was an intraoperative decision. When we measured this, you can see this was measured. I don't know if you can see it on the screen. This measured about 14 millimeters from the base of the defect to the lateral to the base plate. And you can see here we measured about 13 millimeters. You can see that the glenosphere is just below the inferior glenoid rim, and you can see here the graft. So this is the preoperative plan, and you can see that matched up pretty well. And this is using some patient-specific instrumentation to try to get the screw in the right location. And you can see the center screw is a little bit off the alternative center line, but it's pretty close. It's a little bit more retroversion than the plan. And you can also notice, because of this patient's rheumatoid arthritis, that we had to cement the stem in place. And these are rather small bones, so we actually use a small shell implant but a long stem to get the better fixation because of poor quality bone. And here's the bone graft, as you can see. So this is the patient's 6-week postoperative result. You can see, again, we did not let this patient do much motion in the first few weeks because of fear that we would lose fixation. But by 6 months out, he had pretty good fixation. This is his other shoulder. The right side was the non-operative side, but he has some difficulty there and may at some point get a reverse on the other side. But so far, he's happy with the left shoulder and has done well. So again, this is the 6-week postoperative x-ray. You can see the 6-month postoperative x-ray with good, what appears to be good incorporation of the bone graft. You can see we've lateralized the glenosphere for the improved biomechanics that you get, both in terms of the cuff function and the deltoid wraparound and the deltoid effect. And you can see here's the body of the scapula, and there's about a 1 centimeter neck length. So had we not put this bone graft in, you would have not gotten the lateralization. You would not have gotten the benefit of the cuff tensioning or the deltoid wraparound. So again, a lot of the biomechanics that was just presented is very much represented in this particular case, which is pretty challenging. Now, I would say that although this is a very successful result, I was very much prepared to use a bone graft and a hemiarthroplasty if I could not have gotten fixation. And that was a decision that was made at the time of surgery, but a discussion that we had well before the surgery. And I told this patient there was at least a 50% chance that he would not get a single stage reverse. That is very well might be a 2-stage reverse. The second patient is a common problem. And the reason I present this case is because this patient is really the junction between where I think you can do an anatomic augmented glenoid and where you should do a reverse. So it's a B2 glenoid. This person is pretty active and healthy. He's a gastroenterologist at the Cleveland Clinic. He had an intact cuff. Again, good reasons for shoulder replacement. And if you look at his x-rays, this is a fairly typical B2 glenoid, but it's pretty severe. I mean, you can see that the bone loss here is at least 1 centimeter, if not more, that the paleoglenoid, as you can see here, is less than 20, certainly less than 50% of the AP dimension, probably closer to 25%. And there's a lot of medialization. Again, you can see the lateral graded tuberosity is substantially medialized from the lateral acromion. It should be out here. So again, the multiple radiographic findings to show significant glenoid bone loss. And again, the subluxation is at least 50% of the humeral head diameter. This is the patient's opposite shoulder. Again, this is more like a B1 glenoid. And again, I only present this because this is the natural history of a B glenoid. First, you get subluxation, you get B1, goes to B2, and in many cases, in some patients, it'll actually go on to a B3. So the subluxation occurs before the bone loss, and there's some data to support that. So here's the 2D imaging. And again, you see very similarly what you saw on the plain x-rays, but you can also see on this particular view, the sagittal view, the coronal view, that this 2D imaging is not in the plane of the scapula. And you know that because in none of the 2D images on the coronal view do you see the entire scapula on any single view, which means that although this axial cut is perpendicular to the scapula, it is not within the plane of the scapula. And that is the cardinal difference between 3D imaging and 2D imaging when something is not in the plane of the scapula. And the result of that is you sometimes get a very false impression of how much bone loss there is or how much paleoglenoid is left. So in this particular case, this is now a 2D image cut in the plane of the scapula. And you can see this, the paleoglenoid is less than 50% of the AP dimension of the total glenoid. And why is that an important factor? And that is because for you to put the anatomic glenoid at the premorbid joint line, which is represented by the vault model, you have to ream to a significant degree the medializing the glenoid. Or you have to put this particular augmented glenoid in too much retroversion. So you can see the difference. Although this is improved from pathologic version, it's incomplete correction based upon the blue vault model, which shows you the premorbid joint line and the premorbid version. And the consequences of putting it in the correct version is having to medialize the joint line significantly. And you can see in this particular example how much bone you would have to remove relevant to where the premorbid joint line is and how much you get this perforation of the center peg. So if you go back, this is where the center peg should be. This is where the center peg ends up. So this is a good example of severe enough B2 bone loss in primary OA, where at least in my experience and the data that I'll show you, this is the type of patient that a primary reverse, even with an intact cuff, is probably the right thing to do. Now this shows you the difference in the same anatomic glenoid. So this is a stepped augmented component. The patient that I just showed you, where you can see this medialization of the joint line versus a less severe B2, again, with the paleoglenoid being 50%, this is less than 50%. So for this to contact, you have to ream medially, so the paleoglenoid is reamed to match the backside of the anterglenoid component. And on this case, there is minimal reaming required because the paleoglenoid is about 50% and there's less severe bone loss. So in this B2, you can not only correct version, but you can also maintain the normal joint line. And the consequences of this is significant at 2 to 3 year follow-up as it relates to glenoid loosening. So this is a study that's in review now in the JBJS. Hopefully it'll get accepted soon. And we did a comparative study of A1 and A2, which is symmetric glenoid, versus severe B2s and B3s, where we used an augmented glenoid. And we followed these patients for up to 3 years with sequential CT. So these patients had a pre-op CT, as I just showed you. We did the 3D planning. We then got a post-op CT within 3 months of surgery, and then another 3D CT scan at 2 to 3 years follow-up, and looked for glenoid loosening and compared that to the original position of the glenoid component. And what we looked at were 2 criteria. We correlated what we considered ideal placement, which was meant that the version and the inclination were within 10 degrees of the native joint line defined by the vault model, and that it was less than 3 millimeters of vault medialization. So this would not have been achieved in the patient I showed you, where we had to medialize and ream the anterglenoid, and would have been achieved in this other patient. So this would be the criteria by which we did not achieve it. We would have had to medialize it too much versus a patient in which we achieved the correct criteria. And we correlated placement versus loosening, which was osteolysis around the implant with or without implant shift of more than 3 degrees. So this is a representative example. This is a patient with an A1 glenoid. You can see the pre-op, the 2-month post-op, and the 2-year post-op, and the correlation and registration of both the scapular bones, the implant on both the humeral and the glenoid side. And you can see this implant has not shifted at all. There's no osteolysis. Here's a B2 glenoid with an augmented component. Again, similar to what I just showed you as an example, where the the retroversion is corrected and the implant is just slightly lateral to the original joint line. So that would be ideal. And here's a patient with a little bit more severe bone loss where we used a similar augmented component, but you can see it's medialized. You can see that there's perforation of the medial wall of the anterior vault. We did correct retroversion, but at the expense of medialization. And you can even see at 3-year follow-up that there's bone that is formed around the tip of the center peg in response to this peripheral wall perforation. So what we did was we looked at these 160 cases. So 42 were A1 glenoids and 100% of them met the criteria, no augmentation. This was a symmetric glenoid. We had 29 cases of B2 glenoids with the asymmetric step-tech glenoid. 97% of them met the criteria, meaning there was correction of retroversion, correction of inclination, and without medialization of the glenoid. There were 3 of the 29, 10%, had loosening. Only 5% of the A1s. 29% of the B3s had shift and osteolysis, 6 out of 21 cases. And of these cases, 70% of them met the criteria. It means 30% of them did not meet the criteria. And it was not because of lack of correction of version or inclination. It was because of over-reaming and medialization. And you can see here are the cases that were loosened. These are the blue ones are the B3s and the red ones are the B2s. And you can see the cases here that had that are highlighted that had these B3s are the 6 cases that had medialization. And if you look at this from a statistical perspective, it was not the correction of version. There was no statistical difference in correction of version. It was the joint line medialization that correlated with the loosening and the shift. So in these types of patients, and this is that patient, you can see with the small paleoglenoid and the need to over-ream, if you were using an anatomic, it would be better to use the bone graft to lateralize the glenosphere and to treat that. And you can see this, the yellow here represents the graft. So you're going to have, again, about 25% of base plate contact on the glenoid. And this is that same patient. You can see reaming of the glenoid in the front, placement of the guide pin, and then creation of this defect here, and then fashioning of the bone graft. You can see this is a wedge-shaped bone graft, so it's more posteriorly thicker than here, and that gets inserted. We use this as a template to cut out the graft, and we cut this edge off so that goes in there. And this is what that patient looks like at 2-year post-op, and now he's probably about 5 years out, and he's got an excellent result. So the last case I want to present is a cavitary bone loss. This is a typical scenario of patient who had an anatomic glenoid placed, and you can see over the course of many years, this is about 7-year follow-up. You can see early osteolysis around the calcar, and you can see another 7 years later. So now this patient's about 14 years from the arthroplasty. The arthroplasty was done in 2005. You can see severe loosening and osteolysis. And you can see on the metal artifact reduction CT scan, you can see very little metal artifacts. So there is some sequencing that you can have in your hospital so you can do good planning. You can see this is a relatively intact. There may be some wall defect here in the anterior wall. But you can see it's a fairly contained defect, but it's a very, very large cavitary defect. So for me, this is going to require not bone graft morselized, but a structural bone graft. And you can see the 3D planning with the implant out, the size of the defect, and then the 3D planning. You can see this defect in the wall posteriorly and where we would intend to put the graft. So what I usually use is a tricortical iliac crest graft. Difficult to make patient-specific instrumentation with these cases because of the lack of bony landmarks and to some degree the metal artifact. So I use intraoperative navigation or intraoperative radiography to define the location of the guide pin, make sure the base plate's going to be at the lower part of the glenoid vault, and then a tricortical graft that is fashioned, carved to fit into the defect, and then placement of the graft. So this is the patient I showed you earlier. This is different than the intraoperative photos. And you can see the graft in place here. And this is his 6-month post-op follow-up with that tricortical graft. If you look at the outcomes of tricortical graft, this was published in Journal of Shoulder and Elbow in 2019. This was our series of, we had 30 patients, 15 that iliac crest graft for large uncontained defects, much like the patient I just showed you. And we compared those to 15 patients with the same implant that had non-structural graft, where there was at least 50% of the backside of the base plate on native glenoid, so we didn't feel they needed structural graft. And we use this sort of as a control group to see how these patients would do when you compared them. We saw excellent incorporation of the graft in all patients except for one patient. And this patient happened to have a posterior postoperative joint infection, which required revision. The other 14 had no evidence of infection and did quite well. And these, we made a series of measurements, and you could read the article to show, to see what the bone incorporation was. So that's been our standard of care for these cavitary large defects. So this is just an example. I'll show you the intraoperative surgery for doing this case. Here's another case, same type of imaging. You can see the defect, similar to the last one. You can see the preoperative planning for placement of the glenoid. You can see the very large defect here. And this is the intraoperative imaging. You can see here's the axillary nerve. We protect that with a retractor. We use this laminar spreader to be able to get to the back of the shoulder. So the arm is in, the osteotomy surface is parallel to the glenoid. And we use standard instruments to cut out all of the capsule, front, back, and around. And once that's done, you can put in your standard humeral retractor. This is a augmented glenoid that we used. I take away some of the bone in the center to make this a more uniform defect so that the tricortical graft can be fashioned and fit precisely in place. Obviously, you want to preserve the depth of the vault and you want to preserve the walls. And then we take some measurements of the defect. We transpose those measurements to the iliac crest and then use an oscillating saw and some osteotomes to take out the piece. Generally, the piece is about 20 or 30% bigger than the defect itself, so that gives us an opportunity after we clean it off to fashion the graft with a rongeur and burrs, and then once that's done, we try to get a strong press fit, so the graft may be slightly bigger than the defect itself, so that there's some inherent stability before you put in the screws. And the graft, as you can see, is substantially more lateral, bigger than the final one, because you're going to ream this in situ. So then we put in a couple of pins. One pin is going to be the pin we use to ream the graft in situ. We take an intraoperative photograph, intraoperative radiograph, to be sure that we have the right tilt. Again, this is too far lateral, so you're going to ream this, but at least we know the guide pin and the base plate is in the right location. You put a second guide pin in superiorly so that it clears the reamer, but also decreases the torque and the concern about the graft moving with the reamer. You need sharp reamers for this. You need to go slow and not press very hard. And then you're going to ream this so that you get a uniform surface. And because this graft is fairly large, you're going to have to use longer screws than come with this particular instrument set. So the longest screws here are in the low 40 millimeter range. In this particular patient, we use 55 or 60 millimeter screws. So for this particular system, we use the Synthes hip screws, the locking hip screws that work quite well. And you can see, even though I'm turning this, I'm not getting perfect fixation of this graft with the center screw. So I'm going to get a lot of fixation associated with the peripheral screws, predominantly the superior and inferior one. And you can see these screws are not the screws that come with the set, but they work well. They come up to 70, 80 millimeter screws. And with the right screwdriver, you can get these to lock into the plate, the base plate, and get them at the right distance so that you can still put on your glenosphere. I think we're done. So this is the postoperative x-rays. You can see these really long screws that go well past the graft. We obviously had to osteotomize the humeral stem to get out the old stem, and we have a cemented small shell reverse stem. So in summary, there are criteria for successful one-stage reconstruction. You have to obviously have sufficient structural graft on impaction. You want to get the screws, minimum 2 screws past the graft into the glenoid. And if these criteria are not met, then you're going to use a 2-stage glenoid. Thank you for your attention. I hope this was helpful.
Thank you very much, Dr. Iannotti, for this very nice, interesting presentation with the very difficult cases. I'll move on to our last speaker today, Dr. Mohamed Gamal Morsy. He will talk today about reverse shoulder arthroplasty in trauma, in fracture. Dr. Morsy?
Yeah. Thank you, Dr. for inviting me to such a wonderful meeting with nice faculty. It's very difficult to speak after Professor Iannotti, but somehow back to basic with reverse shoulder arthroplasty in trauma situation. Proximal humeral fractures constitute 5% of all fractures, and they are most common in the patients older than 65 years old, and the women affected about in 70% of cases. Medical, functional, and fracture-specific complexities make treatment of these injuries challenging. However, open reduction and internal fixation has remained the gold standard. Previously, 3 or 4 part fracture was treated by hemiarthroplasty described by Dr. Mir, until Dr. Gamal introduced the reverse shoulder arthroplasty in 1985, which is published in French literature in 1987 and approved with FDA in 2004, and was originally described for treatment of cuff tear arthropathy only, and it depends mainly on functioning deltoid muscle. As we just heard from our colleague, that the mechanism of action with the reverse shoulder is the usage of large glenosphere in the glenoid, with the socket in the humerus. This makes the center of rotation shifting medial and inferior. That maximizes the function of the deltoid by increasing the lever arm and recruiting more of the deltoid fibers. Originally, the concept of medialization, as you just heard from the biomechanics, that converts the shear forces to compressive forces at the prosthesis bone interface. This leads to more amount of deltoid fibers lateral to the center of rotation than medial. So the deltoid becomes abductors, elevators, with loose external rotation and internal rotation moment. The newer designs with lateralization improves as well the external and internal rotation, improves the deltoid contour and with less notching. Again, the prerequisite is the functioning deltoid with adequate bone stock to support the glenoid bone components. The indication, as we just said, with rotator cuff arthropathy, painful irreparable cuff without arthritis, revision for cuff tear, and nowadays for acute 4-part proximal humeral fracture. The contraindications with axillary nerve palsy, infection, neuroarthropathy, or glenoid bone loss. No operation without complication. You should put in mind the complications with the reverse shoulder, scapular notching, infection, instability, and excessive deltoid elongation may lead to acromial stress fracture. Now coming to our topic with the reverse shoulder in trauma. The indications for the uses of reverse shoulder arthroplasty in trauma, including older adults, 65 years or more, with unreconstructible 3 or 4 part fracture, head splitting fractures, failed internal fixation, symptomatic malunion or non-union of previous fractures, and failed hemiarthroplasty. Preoperatively, you must have complete history and clinical examination, intact axillary nerve, and if unclear, please do EMG. CT is mandatory with 3D reconstruction, and evaluate any associated glenoid fractures. The contraindications of reverse shoulder in trauma includes deltoid deficiency, axillary nerve dysfunction, insufficient glenoid bone stock, active shoulder infection, medically unfit patients, or high demand patients with huge expectations or neuropathic joints. Going to the surgery, you start with general anesthesia. Usually use interscalene block for the pain control in beach chair position with arm position table. Always be ready with long stem sutures for reconstruction of the tuberosities. You may use the humeral head for any glenoid defects and shoulder retractors. Going with the deltopectoral approach, these are the steps. Remove the fracture clot and bursa. Prepare your tuberosities, and sometimes you need some mobilization. Do a head excision, expose the glenoid, and implant the glenoid part. Then make bone holes around the stem for tuberosity fixation. Then humeral stem implantation, and finally tuberosity fixation and cuff closure. So here we start with the position, the modified beach chair position. We usually use the deltopectoral approach that gives you better preservation for external rotation, deltoid muscle preservation, and better visualization. Here is the incision. Then do dissection with the deltopectoral interval, blunt dissection. Then incision of the deltopectoral fascia. The landmark is the biceps. We usually do biceps stenotomy and exposure of the tuberosities, finally going to the glenoid. Very important to expose the glenoid adequately, excise the labrum, do periglenoid capsulotomy, remove any osteophytes. It's a good tip to tilt the table 10 degrees to the other side to give you wide exposure to the glenoid. To have to deal with any defects, not like that of Professor Iannotti, I mean some small defects. Scrub to remove the cartilage and prepare the edges of the glenoid. It's important to expose the superior and inferior glenoid as well as the anterior and posterior because it is not a circle, it is an oval shape. And use the glenoid sizer sleeve with the inferior wide part putting on the inferior aspect of the glenoid. Then insertion of the central K-wire guide and to make the drill hole in the central part and remove the anterior humel and put your finger anteriorly and reinsert the K-wire parallel to your finger. This is because the inclination of the scapula differs from patient to patient. Then insert the glenoid reamer and make the central hole about 15 millimeters, the commonly used pig of the glenoid. Then do reaming of the glenoid. And here, finally, the bed is prepared for implantation of the base plate. After implantation of the cementless base plate, we use the glenosphere. Usually it is 36 millimeters. And you have to have a good anesthesia relaxation in order to insert the glenosphere. And go after that with the stem preparation. And very important to adjust your version. using between 0 and 20 degrees of retroversion. Finally, I have to make several holes in the shaft of the humerus while passing 80-bone sutures for later closure of the tuberosities. Do the trial reduction. Check the adequate coupling of the prothesis and of the stem and the glenosphere, and the range of motion before going into closure. And very important step is the tuberosity reconstruction. The sutures previously passed into the fracture fragments, passed these sutures through the prothesis and connecting also the shaft to the tuberosities to adequately close the bone around the prothesis. There is a big debate about tuberosity reconstruction in using reverse shoulder arthroplasty in trauma setting. This is a nice article published in 2018 by Pascal Paulo and his colleagues that showed that the adequate anatomic tuberosity healing improves objective and subjective outcomes. And the greater tuberosity excision is associated with worse functional results and increases the risk of post-operative shoulder instability. Again, Pascal published in Journal Shoulder and Elbow in 2019 concerning the reattaching of the tuberosities, and they found that the tuberosity union rate was about 84%. And despite the advanced age of the patients, the tuberosity reattachment and use of bone graft result in a high rate of tuberosity healing. And they found that the tuberosity reconstruction and healing in reverse arthroplasty improve active forward elevation, external rotation, and patient satisfaction. Post-operatively, the patient started with passive range of motion for 2 weeks, then active assisted 6 weeks, and then active range of motion at 12 weeks. Here are some examples of the usage of reverse shoulder arthroplasty in trauma situation. This is a case of 70-year-old male patient with proximal humeral fracture fixed previously with some K-wires and ended with non-union and AVN, and reverse shoulder arthroplasty with tuberosity reconstruction was applied with good results. Another case in 69-year-old male patient with head splitting proximal humeral fracture, and reverse shoulder arthroplasty was used, and you can notice here adequate tuberosity reconstruction around the implant. Another case with 52-year-old male patient with failed previous internal fixation, non-union and AVN, and loss of shoulder function. And use reverse replacement of tuberosity reconstruction for this patient and with happy post-operative range of motion following that procedure. Another case with neglected fracture dislocation in 4 months, for 4 months in a female patient, and we used reverse shoulder arthroplasty that improved marvelously the range of motion post-operative. This is a case of 70-year female patient with acute fracture dislocation of the shoulder, and reverse shoulder replacement with tuberosity reconstruction was applied, and you can see here the intraoperative fluoroscopic view with adequate coupling and range of motion of the prothesis. This is a case of 60-year-old female patient with neglected anterior shoulder dislocation for 6 months. It's fracture dislocation, and you can see intraoperative here that there is anterior glenoid defect that necessitates the usage of part of the head as a graft to fill this defect, and we fix this part with the screw, then we implant the reverse prosthesis over the glenoid. And this is the post-operative X-ray of the patient. Lastly, the case, a young female patient, 39 years, that had a road traffic accident and sustained a comminuted fracture of the proximal humerus, treated firstly with hemiarthroplasty, but with the follow-up 9 months failed hemi with horrible migration of the hemiprothesis under the acromion with loss of function and pain, and we used a reverse shoulder arthroplasty to solve such a problem with a good result of the patient and regaining back of the range of motion. If you go back to the literature to see the outcome of reverse shoulder in trauma, this is a systematic review published 2020 showed good results of the reverse shoulder in trauma. Here, Christian Gerber in 2016 published a paper about the reverse shoulder in for 3-part fracture, and they found that the mid-term clinical results showed good and good results with low complication rate and rapid post. Published in 2019 about the reverse shoulder in trauma, and they've concluded that the reverse shoulder had led to fewer complications compared to internal fixation in elderly patients. Regarding the papers or the systematic review comparing the use of reverse shoulder versus hemiarthroplasty in trauma, this is a nice systematic review published in 2020 showing that superior performance of the reverse shoulder over the hemiarthroplasty. This is a meta-analysis published 2016 suggests that the reverse shoulder arthroplasty in proximal humeral fracture is a better option than hemiarthroplasty in elderly population. Pascal, again 2018, published a systematic review and meta-analysis comparing the reverse shoulder versus hemiarthroplasty, and they found that the functional outcome with reverse shoulder is significantly better and more reproducible than the hemiarthroplasty, with better active range of motion. However, they found that the active internal and external rotation are worse than the hemiarthroplasty, and the reattachment of the tuberosities improves the rotational stability, and even if the tuberosities do not heal, the functional outcomes are satisfactory compared to the hemiarthroplasty. They found that the overall complication rate is higher somewhat to the reverse shoulder arthroplasty, however, the reoperation rate is equal in both. Finally, in 2020, there is a nice paper of reverse shoulder in proximal humeral fracture. They found that the reverse shoulder is increasing while the hemiarthroplasty decreases. The functional outcome scores, range of motion, satisfaction scores are superior when compared to hemi, and they concluded that the revision and reoperation rates are significantly lower in reverse as a placement than in hemiarthroplasty, with a significant improvement in the functional outcomes reported, especially in elder population. So to take home message, actually the use of reverse shoulder arthroplasty in trauma situation can reverse the expectations. Thank you very much. Greetings from my assistant and my fellows here from Egypt. Thank you very much.
Thank you very much, Dr. Mohamed, for this very nice, informative presentation.